Hello everyone, my name is Jami Husain. I am an economist at the Global Non-Communicable Diseases branch in the Division of Global Health Protection at the US Centers for Disease Control and Prevention, CDC. Today, I'm going to present the topic titled Price, Availability and Affordability of Cardiovascular Disease and Hypertension Medicines. As you know, prevention, control, and management of non-communicable diseases like CVD and hypertension generally requires long-term treatment, where sustained accessibility and availability of medicines in the healthcare system are critical. The use of blood pressure-lowering medicines in controlling hypertension and in preventing the CVD events is remarkably suboptimal worldwide, leading to poor blood pressure control at the population level. In many countries and areas, the essential medicines, the antihypertensive medicines are often not available, not accessible, not affordable, or even not acceptable in some cases. Low availability and high costs may play a major role as a barrier to optimum use and adherence to essential antihypertensive medicines, particularly in the low-income settings. This presentation is based on a study in which we examine the price, availability, and affordability of some selected cardiovascular disease and hypertensive medicines based on data from multiple countries. In this presentation, we will talk about the presence of CVD and hypertension medicines on the country essential medicine lists. We will also share some results on the availability, price, and affordability of some selected CVD and hypertensive medicines. And finally, we will discuss the WHO access framework that addresses the issues and challenges related to the selection, access, and availability of medicines.
Careful selection of essential medicines is a crucial step in ensuring access to healthcare and in promoting rational use by health professionals and consumers. Essential medicines are intended to be available within the context of functioning health systems at all times in adequate amounts, in the appropriate dosage forms, with assured quality and adequate information, and at the price the individual and the community can afford. In effect, one of the key requirements for ensuring the availability of any medication within a public health system is its presence on a country's essential medicine list, or EML. An in-depth look at the status of the inclusion of CVD or hypertension medications on country EMLs would help understand the current country-level barriers to access. We analyzed the presence of 12 selected CVD and hypertension medications across the most recent and available National Essential Medicine Lists, or EMLs, in 53 countries. The figure on the left-hand side shows the percent of country EMLs, that is, for each medicine, how many from the 53 country EMLs include the corresponding medicine. We can see that the medicines with the lowest inclusion rates include statins. For example, atorvastatin, lovastatin, pravastatin, and simvastatin all have lower inclusion rates, as well as enalapril and amlodipine. Amlodipine was present, for example, in 38 country EMLs, that is 72% of the 53 country EMLs analyzed. Now, figure on the right-hand side shows that 66% countries included at least one statin, and 70% of the countries included at least one ACE inhibitor. Looking at the gray shaded bar on the right-hand side figure in the bottom, we see that only 57% countries included medicine in EML from all 5 classes of medicines. One limitation to note for this analysis is that we did not take into account variations in the included dosage, strengths, or formulations of the medications. The only inclusion criteria were that the medication was included in the EML in any form. And the inclusion of a medication in the EML does not guarantee that the medicine is procured with appropriate specifications and quality. So it is not guaranteed that mere inclusion in the EML will guarantee a proper procurement. So establishment of a systematic and transparent procedure for defining and updating the national medicine lists for CVD and hypertension medicine on the basis of evidence-based treatment guideline is a critical first step. Now, the WHO and the Health Action International Project on Medicine Prices and Availability developed a survey manual that offers all countries a standardized method for collecting and analyzing medicine price, availability, and affordability across healthcare sectors and regions in a country. The data for this study comes from the country surveys that used WHO HAI methodology, which allows standardized reporting and cross-country comparisons. In this study, we used 84 surveys in 59 countries to examine availability, price, and affordability of 9 selected CVD and hypertension medicines. The availability of a particular medicine is reported as the percentage of medicine outlets in which the medicine was found on the day of the data collection. Price data for individual medicines is presented as a ratio to an international reference price, expressed as the median price ratio, or MPR. This enables national and international comparisons. The international reference prices are the recent procurement prices offered by both not-for-profit and for-profit suppliers to developing countries for multi-source products and are taken from the Management Science for Health International Drug Price Indicator Guide. Affordability is defined as the cost of treatment in relation to people's income. In the WHO HAI methodology, the measure is number of days of work by the lowest paid unskilled national government worker to purchase 30 days medicine. Let's look at the availability situation. The two graphs show availability on the brand and the generic medicines in the public and the private sectors. On the left-hand side graph, we see availabilities for brand medicines. On the right-hand side, we see availability of generic medicines. The dark shaded bars in both graphs represent availability in the public sector, and the light shaded bars represent availability in the private sector. The availability data is also presented for two groups of countries. Blue dots represent the high and upper income countries, and the red dots represent the low and middle income countries. Each of the bars and dots shows the percentage of facilities in which the medicine concerned was available at the time of survey. We can see that large variations in the availability for different medicines are evident in the graphs. In general, the two graphs reveal that A, availability of generic medicines are higher than the brand medicines, as we can see that the bars on the right-hand side figure are taller than the left-hand side figure. B, we see that availability in the private sector is higher than the availability in the public sector, if you compare the dark and light shaded pairs of bars. And finally, availability in high and middle income countries are higher compared to the low and lower middle income countries. It is evident when you compare the blue and red dots for each medicines. For the brand medicines in the left side panel, the average of the availability of select medicines in the public sector is 29% compared to 46% in the private sector. The average availability of the generic medicines in the public sector is 55% compared to 67% in the private sector, which you can see on the right-hand side graph. This figure shows the government procurement prices, expressed as the median price ratio, or MPR, to the international reference price, adjusted for inflation and purchasing power. The darker and lighter shaded bars represent government procurement prices for brand and generic medicines, respectively. Compared to international reference price, the government procurement prices on average were 17 times higher for brand medicines, 4.4 times higher for lowest price generic, 21.7 times higher for brand medicines in the low and lower middle income countries, 13 times higher for brand medicines in the high and upper middle income countries. The procurement price for generics were just above 4 times higher than the international reference price for both higher and lower income countries. Now, among the brand medicines, the medicine-specific MRPs range from 6.5 to 25.2. For instance, the prices for the brand enalapril, the captopril, are 21.8 and 25.2 times higher than the international reference price, respectively. Among the generics, the MRPs range from 1.9 to 15.6. The procurement prices for hydrochlorothiazide and lovastatin are 10.6 and 15.6 times higher than the international reference price, respectively. The two graphs here present the prices patients pay in the public and private sectors for the select brand medicines in the left and the left-hand side and the generic medicines on the right-hand side. Again, the prices are expressed as median price ratios relative to the international reference prices for the respective medicines. Overall, average patient price for the brand medicines are 80.3, indicating that on average, the price for the brand medicines are 80 times higher than the international reference price. The prices for the brand medicines are much lower in the public sector compared to the private sector, with MPRs of 23 versus 98.9. In contrast, on average between the higher and lower income countries, we observe a modest difference in the private sector prices for brand medicines, that is 98 versus 95.2 respectively. There are wide variations in the MPRs of individual brand medicines. The public sector patient prices for captopril and enalapril brand medicines are over 40 times higher than the corresponding international reference prices. The patient prices for brand medicine in private sector for atenolol, enalapril, furosemide, and lovastatin were 184, 179, 139, and 117 times higher than the corresponding international reference prices. Now, looking at the figure in the right-hand side for the generics, the patient prices for generic medicines are much lower compared to the brand medicines, but still many times higher than the international reference price. The averages of the MRPs, the averages of the MPRs for select generic medicines overall, public and private sector are 17, 8, and 26 times higher, respectively. Average patient MPR is higher for patients in low-income settings or low LMICs compared to the high-income countries across all medicine categories. Compared to high and middle-income countries, patient price in the public sector in LMIC are triple for brand medicines and double for the generics. Now come to the affordability results. One of the best ways of illustrating the impact of medicine prices on the cost of healthcare for individual patients and society is to compare the cost of treatment with people's actual incomes. For the WHO HAI survey, the daily wage of the lowest paid unskilled government worker in each country is used for comparison, and affordability is expressed as the number of days the lowest paid unskilled government worker would have to work in order to afford the cost of 30 days of treatment for the chronic condition being analyzed, in this case, the CVD and or hypertension. The y-axis in the graphs represent the number of days wage needed to cover for 1 month or 30 days cost of corresponding medicines. The cost of 1 month's antihypertensive medications were, on average, 6 days wage for brand medicine, as seen on the left-hand side graph, and 1.8 days medicine wage for the generics, as presented on the right-hand side graph. The red dots indicate that affordability is lower, that is, higher number of days of wage required in lower income countries compared to higher income countries, looking at the blue dots for both brand and generics. From looking at the heights of the respective bar in two graphs, for all the medicines analyzed, generics are much more affordable than brand medicines. In this slide, we are talking about the framework for access to essential drugs and medicines. Improving access to essential medicines is perhaps the most complex challenge for all actors in the public, private, and NGO sectors involved in the field of medicine supply. They must all combine their efforts and expertise and work collectively. WHO has formulated a four-part framework to guide and coordinate collective action on access to essential medicines. The first critical element in the access framework entails ensuring rational selection and use of essential medicines with proven efficacy, safety, quality, and cost effectiveness. The next element entails affordable provisioning of those medicines. This can be achieved with a variety of management, regulatory, and policy interventions, including use of available and impartial price information, allowing price competition in the local market, promoting bulk procurement, implementing strong generic policies, negotiating equitable pricing for newer essential medicines, eliminating trade barriers on essential medicines, reducing markups through more efficient distribution and dispensing systems, encouraging local production of essential medicines and assured quality, etc. Long-term use of medications for CVD and hypertension management and treatment is contingent on sustainable financing, which is the third element in the access framework. This requires expanded role of public finance involving governments, NGOs, and donors. Based on the established medication guidelines, public funding for target medicines needs to be increased, including exploring opportunities for external funding, for example, grants, loans, and donations, and other financing mechanisms such as debt relief, solidarity, and pooled funds. Additionally, health insurance through national, local, and employer schemes need to be expanded. The fourth element in the access framework entails presence of a reliable health and supply system. Reliable supply systems requires integrating medicines in health sector development plan, creating efficient public-private NGO mix approaches in supply delivery, assuring quality of medicines through regulatory control, exploring various purchasing schemes, having efficient projections of medicines needed, procurement cooperatives, etc. Critical elements of a reliable health system also include transparency and good governance in the selection, procurement, and use of affordable and effective generics.
In this presentation, we have seen considerable variations in the availability, price, and affordability by medicine between public and private sectors and between brand and generic medicines. Patients in low and lower middle income countries face higher price and lower affordability compared to the high and higher middle income countries for both brand and generic medicines, although generic medicines are much more affordable in all countries. Given that procurement, distribution, and other supply activities can be carried out most efficiently for a limited number of pharmaceutical products, and that CVD and hypertension for a majority of the population can be treated with a limited number of carefully selected medicines, those medicines should be included in the country essential medicine list. And actions that increase access to medicines can include use of effective generics and efficient procurement mechanism. Here I present some recommended readings related to this topic. And the first reference in the list describes the WHO HAI survey methodology, data collection tools, and the ways to conduct analysis using such data. The two published papers by Cameron et al. And Van Morik et al. In reference 2 and 3 present similar analysis on price, availability, and affordability of CVD and hypertension medicines. The last three references from WHO describes all about the essential medicine list, its use, and also about the access framework. Before I conclude, an important disclaimer: the finding and conclusion in this presentation are only mine and do not necessarily represent the official position of the US Centers for Disease Control and Prevention, CDC. I thank you all for listening to this presentation. Bye-bye.